Welcome to St Mary's Assisted Reproductive Treatment. This presentation is for patients who are thinking of having fertility treatment at St Mary's as fee-paying patients of Central Manchester NHS Foundation Trust. You will be looked after at all times by our NHS staff. Any fees you pay will go to our local NHS. In this presentation, we would like to explain to you the stages of treatment and the risks and complications that can happen with this form of treatment. We also describe what you need to do next to have treatment at St Mary's and talk a little bit about payment. We provide three main types of treatment. These are commonly referred to as IUI, IVF and ICSI. Which treatment is right for you depends upon your underlying fertility issue. We will discuss this with you at your consultation and help you come to a decision that suits your own situation and views. You may already have some knowledge about how IVF works. IVF stands for in vitro fertilization and involves the egg and sperm meeting outside the body. The egg is fertilized and an embryo forms, which is transferred into the woman's womb, where it has the opportunity to implant and develop into a baby. In order to collect eggs from the woman, we need to stimulate her ovaries under close monitoring. Once the eggs have been collected, they are mixed with the sperm to achieve fertilization and development of embryos. Embryos can be transferred, hopefully leading to a pregnancy, or frozen for future use. Here we describe the stages of IVF treatment. The first stage is ovarian stimulation, for which you may require downregulation. Stimulation continues until the stage of the trigger injection. Following the trigger, the eggs are collected, fertilized and embryos created. These embryos can be transferred or frozen. Once embryos have been transferred, you are asked to use medication to help support the lining of the womb and to do a urine pregnancy test at home on the day advised. Our staff are there to support you through the process and also to deal with the outcome of treatment. During IVF treatment, we provide the woman with injections that stimulate the development of several eggs in the ovaries. We also need to give you medication that stops your body from releasing these eggs before they are ready to be collected. This can be in the form of an agonist or antagonist. The doctor will discuss which of these is appropriate for you during your consultation. It is essential that you use a method of contraception from the first day of your period and throughout your treatment until after your embryo transfer. The agonist we use is a drug called buserelin. This is given as an injection once a day and usually starts on day 21 of your cycle. You are likely to have a bleed within 2 to 3 weeks of starting this injection. At that stage, we will see you for a blood test to confirm that your ovaries have been switched off. In some cases, you may also need an ultrasound scan. Occasionally, if the ovaries have not been fully downregulated, you may need to continue buserelin for up to 6 weeks. Injections for ovarian stimulation start after we are happy that downregulation has occurred. If you have been prescribed the antagonist regime, injections are not required prior to starting stimulation. The stimulation injections are started between days 1 to 3 of your cycle. We will advise you of the exact date. The antagonist is a second injection that is started on day 4 or 5 of stimulation, given once daily in the morning until the day of the trigger injection. In order to stimulate the ovaries, we use injections of a hormone called FSH. There are several types of FSH which have similar effects, and we will discuss which of these is appropriate for you at your consultation. We will also teach you to do the injections. These are given once a day under the skin. During the ovarian stimulation, we will monitor you with vaginal ultrasound scans and blood tests in our clinic. The first of these monitoring visits will be on either day 6 or day 8 of your stimulation. Once again, we will advise you which date to come to the clinic. You will require further monitoring depending on your response. Monitoring continues until your follicles have reached the stage where a trigger injection can be given. Most women require injections for 8 to 14 days before they reach the stage of the trigger. However, the response to drugs is highly individual, and you may respond in a different way to other patients. Depending on your response to stimulation, we may occasionally advise you to increase or decrease the dose of FSH. Our standard IVF package includes medication for up to 10 days. If more medication is required, it will be provided, and you will be charged separately for this. Once your monitoring shows that the eggs have reached a stage ready for collection, you receive a trigger injection. It is important to take this at the time advised, as the egg collection must be carried out approximately 36 hours after the trigger injection. The egg collection procedure is also known as oocyte retrieval. It takes place in the morning, about 36 hours after the trigger injection. We will give you instructions regarding fasting, as the procedure is carried out under sedation administered by an anaesthetist. There will be a number of staff in theatre for your safety. The procedure usually takes 20 to 30 minutes. You are usually able to go home a few hours after this. After the egg collection, it is important that you have someone with you at home overnight and that you do not drive for 24 hours. It is normal to have some discomfort after the procedure, and it is okay to take paracetamol and/or codeine for this. Please inform us if the pain is not controlled with these medications. We also advise you to start using the progesterone pessaries on the morning of the day after egg collection. The pessaries can be inserted into either the vagina or the back passage. This slide shows how the egg collection procedure is carried out. An internal ultrasound probe is inserted into the vagina to give a picture of the ovaries. Attached to the scan probe is a needle that the doctor is able to pass into the ovaries that are visible on scan. The needle is connected to a suction tube through which the fluid surrounding the eggs is sucked out and passed to the laboratory. On the day the eggs are collected, we also require a sperm sample to try and achieve fertilization of the eggs. In order to get the best sperm sample, it is important for the man to not have ejaculated for 2 to 5 days previously. Occasionally, the sperm sample on the day of egg collection may not be of high quality, and if that happens, we will ask for a second sample. Sometimes our laboratory scientist may recommend changing your treatment from standard IVF to ICSI if the sample is unexpectedly poor. If you are using donated sperm or frozen sperm, this will be thawed out on the day of egg collection. Once we receive the semen sample, we extract the motile or active sperm from the semen. This is done within 30 minutes to an hour of production. The sperm can then be used for your treatment. During the egg retrieval, fluid from the follicles in the ovaries is sucked out and passed to the laboratory. The embryologist examines the fluid under a microscope to locate your eggs. This slide shows what the egg typically looks like when it is first seen under the microscope. If your treatment is IVF, we add the prepared sperm to the eggs and allow the sperm to swim their way to the egg overnight. If your treatment is ICSI, the embryologist first removes the surrounding cells from the egg and checks to see that the egg is mature. Each mature egg is then injected with an individual sperm. On the day following egg collection and insemination, we check to see how many of your eggs have fertilized normally. We do this by looking for what are called pronuclei. They are the male and female genetic material that go into forming the embryo. Our embryologist will telephone you to tell you the results on the morning of the day after egg collection. Eggs that have fertilised normally are moved into a culture dish in the laboratory. Eggs that have not fertilised or fertilised in an abnormal way cannot develop further, and they may be treated in the following ways. They may be donated to ethically approved research if you have consented for this. They may be used for training laboratory staff if you have consented for this. Or they are allowed to perish. These options will be discussed with you at your consultation and the appropriate consent forms completed. Our laboratory is able to offer an innovative technology called Embryoscope that may benefit certain couples. This technology allows our embryologists to monitor your embryos without disturbing their environment and helps us select the most suitable embryos for transfer. Please note that we do not use Embryoscope for all cycles. We have certain criteria based on the number of embryos created and the space available that must be met in order to be eligible for Embryoscope culture. Currently, 2/3 of our patients have their embryos cultured in an Embryoscope. At St Mary's, we do not charge extra for this technology. This is a video recording of embryo development. You can initially see the female and male pronuclei and the embryo then dividing to 2 cells. The Embryoscope uses time-lapse recording technology, which allows us to visualise the 2-cell embryo dividing further to 4 cells and so on. This recording was made in our laboratory here at St Mary's as part of a research project. Eventually, we see the cells in the embryo start to compact together before seeing organisation of the embryo, which reaches the stage of blastocyst on day 5. A blastocyst is the latest stage at which we replace or freeze embryos. Your embryo transfer occurs on day 2, 3 or 5 after egg collection. Our embryologists will advise you of the day and ask you to attend the clinic accordingly. They will also advise you on the number of embryos to be transferred. Our aim is to give you a good chance of success while keeping the risk of multiple pregnancy as low as possible. We use a special medium called Embryo Glue as standard for all our embryo transfers. Research suggests that embryo glue can assist with an increase in the chance of successful implantation of embryos. There is no extra charge for this at St Mary's. Once embryo transfer has occurred, you may be able to have any remaining embryos frozen for future use if you have consented to this. In order to be suitable for freezing, embryos need to be of sufficiently good quality. We find that this is the case in around 1 in 4 treatment cycles. The duration of time for which embryos may be frozen will be discussed with you at your consultation. We also advise you to visit the website of the Human Fertilisation and Embryology Authority and read the HFEA consent forms that will be provided to you. The laboratory at St Mary's has state-of-the-art technology and equipment to take care of your eggs and embryos. This includes high-specification incubators, ICSI rigs and culture media. We also use the latest electronic witnessing system to prevent any mismatching of gametes or embryos, working to ensure patient safety and confidence in our laboratory procedures. These are pictures from the interior of our laboratory. If you have any questions about our facilities or would like to find out more about our processes, please speak to one of our embryologists who will be attending the information session. You will have started the progesterone pessaries on the morning of the day after egg collection. Please continue these until the day of pregnancy test, which we will advise you of after your embryo transfer. If the treatment is unsuccessful and you start to bleed, the pessaries can be stopped. If you conceive, progesterone pessaries should be continued until an ongoing pregnancy or a miscarriage is confirmed on ultrasound scan. If in doubt about what to do, please contact our nurses for advice. This slide shows our clinical pregnancy results for the year 2014, both by number of cycles started and the number of cycles where embryos were transferred. As you can see, the success rate of treatment decreases with increasing age of the woman. Cycles where there are sufficiently good quality embryos to allow culture to blastocyst stage have a particularly good chance of success. In 2014, about 1 in 3 treatment cycles in our centre reached blastocyst stage. Our success rates with the transfer of frozen thawed embryos are shown here. Please bear in mind that not all embryos that are frozen survive thaw. However, there is evidence that in some ways, pregnancies following frozen embryo transfer are at a lower risk of certain complications in pregnancy than those following fresh transfer. We now move on to discuss the risks and complications of IVF treatment. You may get side effects from the agonist, such as hot flushes, headaches, and mood changes. There is a chance that your ovaries may not respond well to stimulation, particularly if your ovarian reserve is low. Sometimes we are able to overcome this problem by using a high dose of FSH, but on occasion there may be no option but to stop the treatment. This can be a very disappointing situation. In these circumstances, if you wish, we will discuss other options, such as donor egg IVF or adoption. An important complication of IVF is ovarian hyperstimulation syndrome, or OHSS. This is especially likely in women with polycystic ovaries or who have had this condition before. In OHSS, the ovaries respond in an uncontrolled way to stimulation, causing abdominal swelling, discomfort, nausea and vomiting. In some cases, hospital admission and procedures may be needed. We can sometimes predict that OHSS is likely and advise you accordingly. For instance, we may ask you to freeze all your embryos, as OHSS can get worse if a pregnancy occurs. If you note these symptoms, it is important that you inform us and seek assistance. Out of hours, please contact the gynecology ward at St Mary's Hospital. It is recognised that babies conceived through IVF or ICSI treatment have a higher chance of low birth weight and preterm birth than babies conceived naturally. Research also shows that congenital abnormalities are more common in children conceived with IVF or ICSI. It appears that this is mainly due to the underlying reason for subfertility rather than the treatment itself. Complications of early pregnancy are also more likely in IVF and ICSI pregnancies. Particularly if you have suffered from tubal disease, the risk of having an ectopic pregnancy is higher. This means that should conception occur, you should report any pain or bleeding and have an ultrasound scan in early pregnancy to check the location of pregnancy and whether it is developing normally. It is recognised that babies conceived through IVF or ICSI treatment have a higher chance of low birth weight and preterm birth than babies conceived naturally. Research also shows that congenital abnormalities are more common in children conceived with IVF or ICSI. It appears that this is mainly due to the underlying reason for subfertility rather than the treatment itself. Complications of early pregnancy are also more likely in IVF and ICSI pregnancies. Particularly if you have suffered from tubal disease, the risk of having an ectopic pregnancy is higher. This means that should conception occur, you should report any pain or bleeding and have an ultrasound scan in early pregnancy to check the location of pregnancy and whether it is developing normally. We are aware that the chance of conceiving a multiple pregnancy is increased if more than one embryo is transferred during an IVF cycle. It is known that twins and higher order multiple pregnancies are associated with a greater risk of complications compared with singleton pregnancies. We follow professional guidelines and aim to give you the best chance of success while trying to keep the risk of multiple birth to a low level. Your medication will be provided to you through our home delivery service. Please ensure that we have your correct address for this. It is important that the drugs are stored as advised by the company. We will teach you how to store and inject your medication. All payments for your treatment will be to Central Manchester NHS Foundation Trust, helping to support the local NHS. Full details of these are available in a financial information leaflet. At the end of your consultation, you would be given a costed treatment plan specific to you, and these costs must be paid in full before your treatment can start. As mentioned earlier, the initial drug package includes up to 10 days of drugs. If further drugs are needed, we will provide these, and they need to be paid for separately. We appreciate that fertility treatment can be an emotionally difficult process for couples and individuals. We have access to independent specialist fertility counsellors, and you can see them at any stage of your treatment. Your counselling is completely confidential and highly recommended. Your fee-paying package includes 2 free appointments with a counsellor. If you wish to take things forward with St Mary's, you have the opportunity today to bring your tests up to date. Following this, we can book you in for your initial consultation. We will also provide you with your HFEA consent forms. Please read through these so that you can get the most from your consultation. Please bring some form of identification and any previous treatment details with you to your consultation. Thank you for your attention. Please feel free to contact us if you wish to take the process forward.